R&M chapter 17. Of the 3 chapters in this module for this week, this chapter will be where most of the test and quiz questions come from. So please, please, please focus on chapter 17. Read the chapter and study this PowerPoint. All right, we'll start with arteriography. It's also known as angiography when we are talking about arteries. We call it angio for short. What we're going to do is use radiation, ionizing radiation, to get images of the arteries into which contrast material has been introduced through a catheter. The contrast medium is going to help the arteries show up on x-ray, so we can use them to check for stenosis, blockages, aneurysms, things like that. It's going to be used when the physician suspects there is peripheral arterial disease. So if the patient has had an ultrasound, say on their lower extremity arteries, and we find a stenosis or a problem, they can have this test done to see if there is a problem, see if we were correct. You can also evaluate abdominal arteries with arteriography. Limitations: you cannot be allergic to iodine. You cannot have this done if you have poor kidney function. You could get a hematoma at the puncture site. A hematoma is a bruise, basically. So you are going to, it is a procedure, it's not a surgery, it's a procedure. So you will have a needle stick, or maybe a little bit bigger, where they will have to put a catheter in. You could end up having numbness from nerve damage at that puncture site. You could have a pseudoaneurysm, which is where they could accidentally nick an artery and blood will escape into its own pouch. You could have a local arterial occlusion from this surgery. You could also have renal dysfunction if you did not before. Not saying these are going to happen. These could happen. Okay, let's talk about a hematoma. Oftentimes you will do an ultrasound, or ultrasound will be ordered post-angio to check for pseudoaneurysm versus hematoma. How do you know what is what? Put the probe on the groin or wherever the surgeon or doctor went in. Find where they inserted the catheter. So typically it's going to be the groin. It could be at the ankle. You'll know when you see the patient, and it's going to be a little bit hard to image there because they have been in the area. There's going to be maybe some blood fluid, things like that. Could be bandages. Anyway, the difference is a hematoma is going to look like this. The tissue looks dark with some possible fluid in there. When you turn on color or Doppler, you will get no flow. Again, how do you know it's a hematoma? You're going to see a defined structure at the site of entry where they inserted a catheter. You're going to see a defined structure in the tissue that has no color flow and no Doppler. A hematoma, which is a bruise. Okay, you could see a pseudoaneurysm. What is that? Well, when they've gone in, they have damaged the arterial wall, leaving a little hole in the arterial wall where blood is escaping into its own pouch. So what you need to do when you're doing these scans to check for pseudoaneurysm versus a hematoma post-surgery, I always identify the common femoral artery and common femoral vein. If they went in the groin. If they went in the groin, I'll identify the arteries at that point, which would be common femoral artery, common femoral vein. I'll take a Doppler, check if they're normal waveforms. Then I'll identify the structure, if there's any structure like a hematoma or this. It looks a little bit different, and when you put color on a pseudoaneurysm, you're going to have color flow. So you can see here. This is a great picture. So down below at the bottom of the color box, you have your common femoral artery. And you can see coming off of that common femoral artery is a neck. And that is where the blood is escaping and it's going into its own little pouch here, this circle area. So this is a pseudoaneurysm. This could be concerning. Okay, the technique of an arteriography. What we're going to do, or not me, I'm not doing this, the doctor will puncture of an artery. Most commonly, they're going to use the common femoral artery in the groin. Sometimes they'll use the axillary brachial. I have seen them use the posterior tibial artery or DP artery in the lower leg. What they're going to do is they're going to puncture the artery and insert a very thin catheter. After they get the catheter in the artery, they're going to put contrast through the catheter. And it's going to show the blood moving through the artery. So they're going to inject a contrast that's going to highlight the blood for the x-ray. When you take the x-ray after contrast has been introduced, it's going to highlight all the arteries on x-ray. When they're done, they're going to remove the catheter. Hemostasis is going to be achieved by manual compression, or sometimes they'll put a closure device. So how do we interpret this, or how does the physician interpret this? Hemodynamically significant stenosis is going to be one that reduces diameter by 50%, therefore total cross-sectional area by 75%. Interpretation is based on how much the artery fills or doesn't fill with contrast. You're not going to be reading these. It's not going to be your job, but these questions are going to be on your board exam. They will give you a picture of an angio and ask you likely, where is the problem? So I need you to be able to look at an angio, know what arteries they are showing on the x-ray, and is it normal or abnormal? So if you turn to page 175 in R&M, look at figure 17.1 and 17.2. 17.1, you see the aorta coming down, the renal arteries will split off to the kidneys first, and then the aorta is going to split into the common iliac arteries. You can see these arteries well because they're highlighted with contrast. On figure 17.2, on A, there's an issue. You see the aorta coming down at top. You see the right iliac going down all the way to the leg. But on the left, there's no common iliac artery there. So there's a problem. That is the problem. You've identified the problem. That's simply what I need you to do. To be able to, again, look at one of these x-rays, know what arteries they're showing, and know what's normal versus abnormal. On B, normal. You can see the aorta coming down, the abdominal aorta splitting into the iliacs, going down to the common femoral, superficial femoral. Now, turn the page to 176, figure 17.3 and 17.4. You can see 17.3 is going to show an aortic occlusion with collaterals. You can see all those little vessels highlighted on the side showing collaterals, which is the body's way of attempting to maintain blood flow. On figure 17.4, the left femoral, this is a left femoral arteriogram, you can see the big gap. So the test question would say, on the left leg, on the left upper leg femoral vein, is this normal or abnormal? You can see the circled area, there's no flow. So that's abnormal. Move down to figure 17.5. You've got an x-ray here showing several areas of filling defects through the aorta and iliac segments. If you compare it to figure 17.1, which is normal on page 175, then turn back to figure 17.5, You see that there are areas that aren't filling as well. Those are areas of concern. Stenoses, okay? So atherosclerotic plaque appears as irregular or smooth on arteriograms. Collaterals are usually going to be present in cases of long-standing occlusion. Okay, so you can see here is a picture of plaque on an aortogram, arteriogram. And here are pictures of collaterals. Right under the kidneys, you can see a bunch of collaterals. That's just going to indicate there's a problem somewhere. All right, let's move on to an aneurysm, which we've been over a little bit before. We know is going to be a dilation of the artery. It's when the artery doubles in size of normal or what it was previously. A lot of times when you have an aneurysm, you're going to see thrombus develop along the wall. All right, here is an aorta, an aneurysm of the aorta on ultrasound. We haven't done aorta. We're going to do it soon, but this is an aorta measuring, let's see, 4.3 centimeters. A normal measures under 3 centimeters, so this is a dilation abnormal. A vasospasm can cause severe narrowing of an arterial lumen, usually in small arteries. Okay, fibromuscular dysplasia. This is important. What it is going to cause is several areas of stenosis, which are going to be caused by medial hyperplasia and create what's called a string of beads. So anytime you hear the term string of beads or multiple arterial stenoses that are not caused by atherosclerotic plaque, you need to think fibromuscular dysplasia, which is for short we call FMD. Look on page 177 in R&M, figure 17.7. You can see in the renal artery there, it looks like there are bright little beads. There's an arrow pointing to it. That's a picture there of what it would look like on an x-ray. You're also going to have a post-stenotic dilation. So after all these string of beads, the artery will dilate. Here's a picture again of the kidney. It typically affects the renal arteries in the kidney or the ICA. I've seen it in the ICA a handful of times. It's really hard to appreciate in the renal artery. I have scanned patients with this known in the renal artery, and what I can only appreciate is multiple stenoses. It's really hard to see on ultrasound with the renal artery, but I've seen it in the ICA, and what you're going to see is just multiple stenoses, and then again that string of bead-like appearance. So know this ultrasound picture here on the right, be able to identify that. If I gave you a picture, be able to identify that could possibly indicate FMD. Okay, we're going to move on to page 178 and talk about MRI and MRA. This is the use of radio frequency energy and strong magnetic field to produce a multiplanar images. Does not use contrast agents. It can evaluate abdominal aortic aneurysms and dissections. Can evaluate peripheral arterial disease as well. The limitations of MRI and MRA: you cannot have a pacemaker, monitoring equipment, or other medical objects such as surgical clips. The degree of stenosis is very difficult to assess accurately. Stenosis may be overestimated with MRI and MRA. It's very expensive, and patients tend to get claustrophobic because it's a small tube you have to go through. Okay, let's move on to page 179, CT and CTA. It's going to use ionizing radiation to obtain a cross-sectional image of anatomic structures. Can be performed with or without contrast agents. Can help define relationship of the aorta to renal artery origins, which is very hard to identify with ultrasound. Can look at aortic aneurysms or dissection. The limitations of CT and CTA: images can be degraded by patient motion. They have to stay really still during this. And the presence of surgical clips can shadow over any pathology. It's going to require time. It's expensive, limited in peripheral arterial disease because of small vessel size. Renal insufficiency is a limitation for undergoing CTA. So if you have poor renal function, poor kidney function, you cannot have a CTA. Medical therapy, they want you to stop smoking because it has been shown to cause a lot of problems in vascular disease. Regular and consistent exercise to promote and develop collaterals. Weight control and low cholesterol diet. Statins to be a standard part of medical therapy. Aspirin regimen. Antihypertensive drugs to keep the blood pressure low. Protection to prevent injury. Surgical therapy. All right, let's talk about these. So, I am on page 80 of R&M. Endarterectomy is going to be the removal of atherosclerotic material or plaque from an artery. A bypass graft is going to provide an alternate pathway for distal blood flow around a significant stenosis or occlusion. Common bypass grafts include aorta to iliac arteries, aorta to bifemoral artery, femoral to popliteal artery, femoral to posterior tibial artery, or axillary to femoral, or femoral to femoral. All right, here's a picture of endarterectomy in the ICA. So they will actually open the neck, open the ICA, and take out the plaque. Now, here's an example of a bypass graft. When I'm saying bypass graft, examples include femoral to popliteal artery. You can see here they've taken, a patient has a blockage in the what looks like distal superficial femoral artery. They will try to do different things, as in go in and just remove the plaque. They can try, which is called atherosclerectomy, or they will try to put a stent in, which just pushes the plaque up against the wall and holds the artery open. If none of that is successful, the last option will be to do a bypass graft around the stenosis. So what they do is they hook in above the stenosis where there's flow, the artery's open, bypass the stenosis, and then hook back in underneath where the artery's open. So if you imagine this is like an interstate and there's a wreck on the interstate, it's like you taking a back road around the wreck to where the wreck is passed and you get back on the interstate. And we term the graft wherever it's hooked into. So this one is femoral to what appears to be popliteal. So this would be called a fem-pop graft. Okay, endovascular therapy. This is what they try to do before they do a open surgery like an endarterectomy or a bypass graft. Endarterectomy and bypass grafts are what we call open surgeries. So the patient has to be in the hospital in an OR. They're going to open the patient all the way up. Big scars, ICU stays, a lot of recovery. Endovascular is not considered open. It is a lot easier on the patient, usually can be done in an outpatient setting. So what they'll do is they're going to use a catheter into a vessel, like we said, either common femoral, PTA, DPA, axillary, radial. They're going to try to get access into that artery and thread a catheter through. They're going to use angioplasty, which is just the mechanical widening of the plaque. So they'll thread a catheter through, identify where the stenosis is, and then try to angioplasty. They'll get where the stenosis or blockages are, take a balloon and push the plaque up against the wall. They're going to use oftentimes intravascular ultrasound, which is called IVUS. It's a procedure that uses ultrasound inside the blood vessel to see what's going on, see what the stenosis is and what it looks like. They can also use what's called a stent. So it is like a balloon, but the stent is going to push the plaque up against the wall, and the stent will remain in the artery, in the leg. You'll be able to see these when you're scanning a lot of these patients. You're going to see a stent. You'll know 75% of the time you can tell that it's a stent because it's going to identify very bright as you're scanning down the artery. Okay, angioplasty. So here's a balloon angioplasty. The first picture on top is going to be the catheter inserted through the stenosis. The second one, you can see the balloon. They inflate it and it pushes all that plaque up against the wall. After they do that, they deflate the balloon and remove the catheter out. Stent evaluation again. Normal stented arteries, when you see a stent or know that they have a stent in an artery, it is normal to have elevated velocities. Stents are going to reduce the compliance of an artery. It makes the artery harder, so it's not as compliant. It's critical to identify lumen narrowing. So again, it's hard when you have a stent because it's normal to have an elevated velocity through a stent. So when you term that there's a stenosis, you need to really try to identify plaque and not just go off velocity when you have a stent. Here's a stent. You can see the artery number 1 is an artery with plaque buildup. That's a significant stenosis there. They're going to thread the catheter through the artery up to the stenosis. They're going to inflate or deploy the stent, and then the stent stays in the artery forever. Number 4. Embolectomy or thrombectomy. That's going to be surgical removal of an embolus that is blocking blood circulation. So thrombectomy usually is going to be from a vein. They're going to take the clot out. Arthrorectomy is removing atherosclerotic plaque from the large blood vessels. So atherectomy, instead of doing angioplasty, is where they take the balloon up and push the plaque up against the wall. A stent is the same thing, but the stent, they'll push the plaque up against the wall and the stent will stay in place. Arthrorectomy is they're going to go and actually remove the plaque. They're not going to push it against the wall. They're going to take it out of the artery. All right, so pseudoaneurysm again is something we often see, not often, but sometimes can see post-procedure. It's going to be, again, where you have that nick in the artery, blood flow is going to escape into its own little pouch. It can be very dangerous. So what are things we do to treat pseudoaneurysms after we identify it? Number 1, do nothing. If it's small, oftentimes we'll just check it in a week or so and see if it takes care of itself. If it's small, oftentimes it will thrombose or clot off itself. Number 2, the sonographer can apply manual compression with the ultrasound probe. You need to identify it and press down, usually 45 to 60 minutes. Can be very difficult for the sonographer. Number 3, they can inject what's called thrombin. So you will scan and identify the pseudoaneurysm, and you will help the doctor guide a needle in to inject thrombin into the pseudo, which will clot the pseudo off. And number 4 is an open surgery. This usually happens when the pseudoaneurysm is too large for all these other options. They'll have to go into the hospital, into the OR, be opened up, and have the pseudo fixed. Again, please make sure to review this chapter heavily. Quiz number 6 is going to be around 28 questions. We'll have this next week. Make sure you know what FMD is, how to identify it on x-ray and ultrasound. Know what atherosclerectomy is. Pseudo. What is a pseudoaneurysm? How do you treat it? How do you identify it on ultrasound? What is IVUS? IVUS, where we go inside the artery with ultrasound and identify stenosis during a procedure, angio procedure. What is stent versus angioplasty versus endarterectomy? Bypass grafts of the lower extremity. What are different types? There are multiple different types you can use for a bypass graft. One is called PTFE. That is a foreign material that they'll place in. You can also use your greater saphenous vein, the patient's own greater saphenous. So they will either take the greater saphenous, if it's a big enough size, and hook it in right to wherever they need to, say fem pop. Or sometimes they take the entire greater saphenous out, flip it around, and hook it in. Now, why they do all of this, or leave the GSV in place, which is called in situ GSV versus reverse greater saphenous, I'm not sure. But I know that it is always better to use your own vein, your own greater saphenous vein for a bypass graft, as opposed to a foreign material, PTFE. It's known to last longer if you use your own vein. Let's see. MRI, what are the limitations for MRI? What would be a reason why you couldn't have an MRI? CT, what is a CT? What are the common arteries that are used for access during an angiogram? What arteries do they usually use? What are some complications you can get from arteriography? As far as the past 2 chapters that we've reviewed this week, not a lot going to come from there. Maybe how do you calculate a PBI, and what are the normal and abnormal waveforms we're looking for? Transcutaneous oximetry, what does it do? Why do we use it? Things like that. Again, the bulk of the questions are going to come from chapter 17 here. So make sure you read, and review the PowerPoints.